And again, Dana, thank you for the introduction. And I just want to apologize to everyone for being a few minutes late here. I did just run up from the operating room. But I am so happy to be here to discuss red eyes with you guys. Um, these community lectures are an important part of education for patients and just the general community. Certainly, I think all of us here, or I know I speak for all of the physicians here at UC Irvine at Gavin Herbert, that we believe that patient education is very important and that we consider all of our patients as partners we want you to be partners in your care. And part of being a good partner is having the knowledge with which to discuss your treatments or your care with your physician. So with that in mind, I don't believe I can share my screen. I think I'm listed as a participant here. So would you be able to do that? And if so, can I then advance the slides? So again, we're going to talk about red eyes today. These are my financial disclosures, none of which are relevant to the discussion today. I serve as consultant for several companies here. And let's see. Okay. So the first thing that you need to know, red eyes are probably one of the most common symptoms that people have for which they come in to an ophthalmologist or an optometrist's office. But what you need to understand is that the red eyes are actually a symptom. They're not a disease by itself. So one of the most important things that I wanted to communicate with you today was, when can you sit on it? When do you say, well, the eye's red, it's not bothering me too much, can I just wait? And when should you come in? Or when should you call either your primary care doctor or an ophthalmologist or optometrist? So I always like to use this acronym of RSVP. It's easy for people to remember. So remember redness. If you have sensitivity to light, if you have vision loss, or if you have pain that accompanies the redness, those are all urgent matters and you should be seen rapidly by an eye care professional, or at the very least by your primary care doctor, who can then refer you if needed. But there are a number of causes of red eye, and so we think about these things in terms of what's visually threatening and what's non-vision threatening. And so if we talk about non-vision threatening, we can think of, and I'll go into more detail for many of these, but you can think about subconjunctival hemorrhage. So this is something like a bruise on the eye. Typically, this appears as kind of a solid red patch on the eye. People may have a little bit of pain, but usually it's not too painful. Oftentimes, patients wake up with it. It can be caused by a number of things, including if you're exercising more heavily, especially exercises that increase your abdominal pressure, where you have to kind of bear down, like lifting heavy things, if you're moving furniture, doing sit-ups or push-ups, lifting heavy weights. If you've had trauma to the eye, any kind of blunt trauma to the eye can also cause that kind of hemorrhage. But what's important for many people, especially as we get older, is that this red spot on the eye can be associated with increased blood pressure, a spike in blood pressure. So if you have a history of hypertension or high blood pressure and you develop this red spot on your eye, that can be a sign that the blood pressure is not as well controlled as we would like. And so it's important that we check that. We can also look at what's more commonly known as a stye, but we in ophthalmology refer to it as either a hordeolum or a chalazion. And again, I'll go into more details about this, but these are typically when people get kind of like a bump on their eyelid. It's swollen, it's tender, and the lid is oftentimes more red than the eye itself, but the eye can become inflamed, being sort of continuous or close to the eyelid itself. Blepharitis is another eyelid disease that can cause red eye. Blepharitis means inflammation of the eyelids, and typically blepharitis is caused by an accumulation of bacteria on the base of the eyelashes. Sometimes there are certain kinds of mites, one that's called Demodex, which is fairly common, that can also cause this kind of inflammation. And other times it can be an inflammation of the oil glands that are within each eyelid that can then become blocked up, similar to acne, that can then cause some redness of the eye. Conjunctivitis is something that we're familiar with, and there are actually many different types of conjunctivitis, although the one that most people typically think about is pink eye. And so pink eye is classically viral conjunctivitis. Patients develop a red eye. Oftentimes they'll have discharge. Usually it's watery. It may also cause stickiness of the eyelids. So patients oftentimes will wake up in the morning and they feel like the eyelids are stuck together. They can't open them. They're kind of matted together. And oftentimes it's preceded by a upper respiratory infection, but it may also be associated with contact with other sick people. So many times teachers, people that work with children may get it. People that work in institutional settings, hospitals or prisons, may also get that. And it's fairly contagious. So again, if you've had contact with someone or been around someone, maybe at work that has it, and they're touching their keyboard, you're touching their keyboard, and you kind of rub your eye, that may then transmit that virus that causes that conjunctivitis or inflammation of the superficial part of the eye. Dry eye, which is very common around Southern California, can also cause the eyes to become red. Many people notice this if they take a long plane flight, they kind of get up, or if they haven't been sleeping very well, that can also cause the redness, usually due to dryness of the eyes. Corneal abrasion or erosion, this is where there's a scratched cornea. That can cause a red eye, but you almost always in those situations, patients will have significant pain that's associated with it. They're actually probably the highest or one of the highest densities of nerve fibers goes to your cornea, which is the front surface of the eye. And if that gets scratched, your body tells you in no uncertain terms. And it's quite painful. The good news is that the cornea heals very quickly, typically within 24 to 48 hours. So the pain's not indefinite there. Nasolacrimal duct obstruction. So the nasolacrimal duct is a duct that drains your tears. It goes from your corner of your eyelid here down into your nose. And if there's an obstruction there, then the tears can't drain. Part of the reason that the tears, part of the function for the tears is to sort of flush all the bacteria off your eye. And so you can imagine that if that's not occurring, if the tears are not draining, then it's almost like the tears are standing water and the bacteria tends to grow in there and you can get an infection. So those are all the non-vision threatening things. These are certainly not nothing kind of syndromes or diseases, but they're also not anything that's an absolute emergency to be taken care of that day. However, on the other end here, let's see if we get good. We have preseptal cellulitis. These things are visually threatening. So preseptal or orbital cellulitis, this has to do with infections in the tissues around the eye here. And when that happens, if the infection extends into the orbit, which is the sort of space in which the eye sits, kind of in your skull, then that can actually affect a number of other nerves and potentially can spread into brain tissue if it's really bad. So these are things where if we notice that the infection seems to be spreading or prominent, especially within the orbit, we want to treat the patient with antibiotics, usually systemic antibiotics. If it's very bad, we put the patients on IV antibiotics, and we may even hospitalize them for a couple of days to make sure that they get better. A non-infectious inflammation of the orbit is called orbital pseudotumor. Again, pseudo is like a tumor. And so this occurs, we don't actually know specifically why this happens in certain patients. There are a couple of certain types of diseases that may present with this kind of pseudotumor, but typically patients will get inflammation or swelling around the eye. And accompanying that, they will get a red eye as well. So again, these types of things are not, you don't typically just have an isolated red eye. There's also these other signs that I'll go over with you that will tell you that you should go into the doctor. Stevens-Johnson syndrome, or TEN, is a severe allergic reaction. Sometimes this can occur due to medications that people take. Sulfa antibiotics are often a culprit here. When patients take these antibiotics, and it's a fairly rare syndrome, so I don't think it's something that you generally need to be concerned with. But Rarely patients take these medications. They will get red eyes. Oftentimes it can cause ulcerations or inflammations on the insides of the eyelids and the conjunctiva, again, that tissue that sits over the white part of the eye. And when that happens, it can cause scarring. It may affect other mucous membranes, so the mouth also may develop ulcers, the esophagus. This can be quite a severe syndrome, and these patients oftentimes are hospitalized in the intensive care unit when it occurs. Bacterial conjunctivitis is a little bit different than viral conjunctivitis, which I described earlier. With bacterial conjunctivitis, generally you'll have a red eye, you'll have discharge, but it's almost kind of milky. It'll be like almost like a pus. And when patients get that, again, most bacterial conjunctivitis is mild. It goes away on its own within a week, usually whether or not you use drops. But there are some types of bacteria that can actually cause further damage, especially to the cornea, the front surface of the eye. And again, I'll go over those in a little bit. We talked about corneal infection. This leads us into corneal infections, or what we call corneal ulcers. These are typically infections of the clear tissue that sits on the front of the eye over the colored part of your eye. So there's actually almost like a windshield there. And when that gets infected, that can be very painful, similar to the corneal abrasion that I described earlier. And that can also cause a red eye. We typically see corneal infections in patients that have had trauma to the cornea, or sometimes patients that wear contact lenses, especially patients that sleep in their contact lenses. So as a public service announcement here, please don't sleep in your contact lenses, no matter what your optometrist tells you. And if they say, hey, these are 2-week, 4-week lenses, absolutely not. Take them out every night. Uveitis. So this is actually one of my areas of expertise besides being a cornea specialist. But uveitis is an inflammation of the eye. It's similar to an arthritis, but it's of the eye. So many patients with autoimmune diseases, things like rheumatoid arthritis or lupus, can get inflammation in the eye, and that can cause a redness as well. There are other symptoms which I'll go over shortly. And the last one that is visually threatening that I think can be pretty significant is glaucoma. And some people will get an acute glaucoma. It's a sudden rise in the pressure in their eyes. And when that happens, the eye can become painful. There can be changes in vision, but the pressure goes up quite high. If the pressure stays up, that can cause damage to the optic nerve, and that will cause a reduction or a loss in vision. So again, we want to protect the optic nerve. We want to make sure that we don't have high pressures for a long time. If there is a sudden rise in pressure, we can perform a procedure, usually with a laser in the office, that can treat that and bring the pressure right down. And again, we'll go over all of these further in case you didn't catch everything that I was talking about. So we typically try to approach the red eye as an anatomical approach. So we try to look at each part of the eye and see if there are any abnormalities that may be causing the red eye. Again, just to reiterate, red eye by itself is not a disease. It's simply a symptom. It's your eye trying to tell us that something's wrong. So we want to look at these other parts of the eye to see what's going on. So we might look at your eyelids. Again, we're looking at things like blepharitis, that's an inflammation, chalazion, which is that stye, or molluscum, which is a type of infection that can cause these small little bumps along the eyelid, and then can cause chronic redness as well. We talked about looking at the orbit for infections or inflammations. We talked about the lacrimal system, which is the drainage canal of the eye. It might talk about inflammation of various parts of that drainage canal or infections. We discussed conjunctiva, which is, we discussed conjunctivitis or the hemorrhage that might occur with high blood pressure. People also will get something called a pterygium or a pingueculum, especially here in Southern California or areas where there's quite a bit of sun exposure and ultraviolet or wind exposure. Many times we call this surfer's eye because surfers get it quite commonly because they're out on the water, no sunglasses, and they have this ultraviolet light hitting their eye. And I'll show you what this looks like later, but it generally looks like a growth that occurs from the white part of the eye onto the cornea. And pterygium comes from, I think it's the Greek word that means wing. So it almost looks like a wing shape. So in my left eye, it might look kind of like a triangle with the apex of the triangle towards my cornea or the front surface of the eye. With the cornea, we look for infections. We'll look for some sort of inflammation or irritation, which we would call keratitis. It's kind of a general term. We may also look for an ulcer. That's that corneal infection. And finally, when we're looking at the front of the eye, the anterior chamber is the space between the cornea and the colored part of your eye or the iris. And sometimes there's always fluid in there, but sometimes we can look in and see white blood cells or inflammatory cells, and that tells us that there's this inflammation or perhaps even an infection on the internal part of the eye. So let's talk about the lids in orbit. Many of you may or may not know the anatomy of the eye, but just briefly, this is a cross section here, and what we're looking at is the upper eyelid and the lower eyelid, both of these are upper eyelid, excuse me. But what these show you is that the eyelid is not simply a flap of skin that goes up and down. It actually has muscles in there. There are the eyelashes, and then adjacent to the part of the eyelid that touches the eyeball itself, there is a small oil gland there called the meibomian gland. And that releases oils onto the surface of the eye, and that helps to keep the tears on the eye longer. It prevents them from breaking up. It keeps your eye moist. The inner layer of the eyelid is coated in that conjunctiva, which is that very superficial layer of the eyeball. So what's important here, what I like to mention, is that conjunctiva on the inner part of the eyelid is actually continuous with the conjunctiva on the surface of the eyeball. So we always hear about people saying, oh gosh, did I lose a contact? Did it go behind my eye? It can't actually, because of the way the conjunctiva kind of reflects back onto the surface of the eye, it forms a pocket both on the top and the bottom. And so you can lose a contact up into that pocket, but it's never going to go back behind your eye. And so again, the other reason that's important is because we can look for certain changes in that conjunctiva on the eyelid that will give us clues as to what might be causing the problem for the red eye. So as I mentioned before, blepharitis is typically a chronic inflammation of the eyelid. It may also be associated with a hypersensitivity reaction to bacteria called Staphylococcus and the toxins that those Staphylococcus emit. So another thing to remember is that the surface of our eye actually has bacteria on it normally. And each of those populations, different types of bacteria, actually keep each other in check. They prevent any one bacteria from overgrowing. And that kind of prevents you from developing any kinds of infections. But every now and again, there may be something that causes a certain bacteria to overgrow. And they can then create these problems, typically things like itching, burning. You might feel like the eye has sand or grit. You may have increased tearing. But more specifically, if you have crusting on the eyelashes, as you can see here in the middle picture, and it doesn't have to be that severe, but if you do have crusting on the eyelashes, that's usually an indication, especially if it's kind of a golden or a golden brown crust, that's typically an indication that there's an overgrowth of Staphylococcus. And there are over-the-counter wipes that you can buy. There are different brands. One's called OcuSoft, OcuSoft, which come as these little towelettes, and you can use those to kind of brush or massage or get rid of those crusting areas and reduce the bacterial load on the eyelashes, and that will help. Another thing you can do if you don't want to go out and buy those is actually baby shampoo diluted, just a few drops in the cap of the shampoo bottle with a little bit of water. Use a Q-tip and kind of apply it. You can brush off those Staphylococcus bacteria, and the baby shampoo actually does quite a good job. We've compared it. One of my colleagues, Dr. Tao, has actually compared it head-to-head in a research study with povidone or betadine, and found that it was actually relatively similar to some of the other cleansers that we use. And it's relatively gentle. It's not going to cause irritation to the eye. So baby shampoo works well for this. In some cases, for some patients, we might actually put them on an antibiotic, combination antibiotic steroid ointment or drops. And what that does is to reduce the bacterial load, but it also reduces the inflammation that's caused by the bacteria. Just like other parts of your body, many of the issues on the eye, even if they are an infection, the symptoms you're getting are actually coming from inflammation. It's your body's response to that infection that's causing the symptoms. So we treat with a combination medication, we treat not only the bacteria, but we also treat the inflammation with the steroid, like as an anti-inflammatory, and that can kind of help resolve these things more quickly. In some cases, we will give patients oral antibiotics or antibiotic tablets that go by mouth. Doxycycline is typically used. This is a medication. When we use it at a very low dose. And so that low dose is actually almost not even antibiotic at that point. It has an anti-inflammatory component, and it also has the secondary effect of modifying the oils that are coming out of the oil glands. So as you can see here in the last slide, when we have these oil glands that are blocked up, we can actually see that that will lead to these chalazion or stye. And so if we can treat patients with this doxycycline or even using warm compresses on the eyes, usually like a towel soaked in, not scalding hot water, but fairly warm water, and then put over the eyelids for 5 to 10 minutes, can help those oil glands flow more freely and can reduce things like chalazion or a stye. Again, this is chalazion. You can see here in the upper photo that there are that bump there. Typically, patients will get swelling and tenderness, as I discussed. And the treatment is, as I was describing before, typically we'll use warm compresses. Sometimes we'll use an antibiotic steroid ointment. In some cases, if it's not clearing, most of the time this will clear after a few weeks. It's usually worse in the first couple of days. It may get worse before it gets better. In other words, just like a acne or a zit, once it finally comes to a head, it may then drain, usually out of the edge of the eyelid margin there. And it'll get better after it starts to drain. But if it doesn't, sometimes we can use steroid injections to those areas to reduce it, to help that inflammation go down. We can also use what we call incision and curettage, meaning that like my colleague, Dr. Tao, one of our eyelid specialists, will go in, make an incision on the inside of the eyelid and actually kind of scoop out the stye from the inside of the eyelid and kind of leave it open so that it drains. One thing I want to mention about steroid injections, if it does come up, is if anybody who has more pigmented skin, so not white skin, if you get that steroid injection, it can cause depigmentation or a whitening of that area. So you want to be mindful of that, about going that route in therapy if you do have darker skin. Canaliculitis. So the canaliculus is the drainage canal here. And sometimes you can get an infection. Sometimes it's caused by, there can be a stone. You can get, just like you can get gallstones, you can get small stones in there, and bacteria can build up. Sometimes it's just a blockage. So if there is any discharge, typically patients will have kind of a milky discharge. You might also have more tearing on that side and a red eye. We'll culture that to check and see what kind of bacteria it is, and then we'll start patients on antibiotics. And again, we typically give patients antibiotics by mouth so that we can get enough antibiotics to that area, as well as eye drops. We tell patients to use warm compresses. Sometimes we'll actually do what's called a probing and irrigation. So we'll actually push a little bit, like not a needle, but a cannula. So it's like kind of a blunt needle through the hole in the eyelid, and we'll push a little bit of fluid, sometimes some penicillin and some iodine there, to kind of sterilize the area, but also move out any blockages there. In more severe cases, we might have to actually go surgically and open that area up. And in cases of fungus, we will start patients on nystatin drops, which is an antifungal. So moving further down, dacryocystitis cystitis is an inflammation of the lacrimal sac. So as you can see here, there's an elevation or a bulge there. The lacrimal sac is right here. And as you can see where I'm pointing next to my eye and on my nose. So in cases like this, definitely you'll see a swelling. People will oftentimes, there'll be some tenderness there. Usually you can use warm compresses and some antibiotics, but in some cases, again, you'll have to open it up and drain it. In rare cases, you may actually have to go in and once it's controlled, if it seems like there's an anatomical reason that it keeps getting blocked and bacteria build up, they'll go in and put in kind of a tube in there to help keep it open. But there's generally patients have pain, redness, discharge, and swelling in that area. Dacryoadenitis, I won't spend too much time on this because it's a relatively rare occurrence, but it's usually an inflammation of the lacrimal gland, which is one of the glands that produces tears. And typically it's underneath the rim of your skull, which is right here on the upper brow. Just underneath there, you'll see typically some swelling, but oftentimes you'll get swelling on the outer 1/3 of the upper eyelids. And we see this more often in kids, but sometimes you'll see it in adults. There's a variety of things that can cause it, including inflammation or um, bacteria. And in cases like this, we'll typically start with treating for an infection. If that doesn't work, then we'll make sure that there's not a mass and then perhaps treat with anti-inflammatories there. I noticed there are some questions that are coming up in the chat. I'll answer those at the end just so that we can kind of keep things moving here. But I will address those. So let's move on to the conjunctiva. So the conjunctiva here, as you can see, I talked about it sort of being continuous with the conjunctiva on the inside aspect of the eyelid. So you can see, let's see if I can draw it here. And you can see here that it's that conjunctiva. So that is a thin tissue. It's clear. It has blood vessels in it. And so usually people don't notice it when they don't have any inflammation, but when they get something irritating their inflammation, or those blood vessels that are in the conjunctiva will dilate, they'll expand. And so although the blood vessels are always there, even in someone that has a very white eye, when they get irritated, the blood vessels expand and then they become more prominent. And that's what people notice as like a pinkness or a redness to the eyes. So conjunctivitis is infection or inflammation of the conjunctiva. Let me see if I can erase those. There we go. Is a inflammation or an infection of that tissue. And in a simple conjunctivitis, people typically describe red eye. They have discharge. Oftentimes it's worse in the morning. They may also have some itching or foreign body sensation, something like sand or grit in the eye. And as I said before, oftentimes patients have a history of an upper respiratory illness. If it's lasting long, typically these things are self-limited when it's associated with a virus, usually, or even bacteria. Sometimes over 1 to 2 weeks, it typically gets better. So if it's lasting longer than that, then that's something that we definitely want to investigate and look into. Follicular conjunctivitis. So follicles are these small bumps that are located on the palpebral. So that's the inner conjunctiva of the eyelid. And typically you'll see these, they almost look like little white grapes. And there's, kind of dome shaped. The most common source of this is the viral conjunctivitis. It can occur with a virus called adenovirus, which is quite common. But it can also occur with a herpes simplex virus, which people oftentimes think of that as a sexually transmitted disease. But herpes simplex actually causes a number of other conditions, including just rashes on the skin. It can also cause eye problems, and it's the common cause for cold sores in the mouth. So all of these things are caused by the same virus. With papillae, it's a little bit different. And so these are kind of these small bumps as well, but they tend to have a small blood vessel in the center. And they're most commonly associated with allergic disease. So patients that have allergies, sometimes patients that wear contact lenses chronically, because the contact lenses kind of chronically irritate the eyes. And so if you look underneath the upper eyelid, you'll see these bumps as well. In rare instances, in patients that wear contact lenses, they get a severe allergic reaction. They can actually get very large papillae there, and the eyelid will kind of droop. They'll get more swelling there. So again, if you're a contact lens wearer and you develop those sort of symptoms, you definitely want to have your doctor take a look. The etiology, which means the cause for this kind of conjunctivitis, can range from gonococcus, which is a severe type of bacteria, which is associated with sexually transmitted diseases. It can cause a very severe pussy kind of discharge. You can have other bacteria, which the discharge is there, but it's not too bad. Allergies, as I described, there's a specific type of allergic conjunctivitis called vernal, which occurs typically in the spring and usually in younger patients. That can also, it's seasonal, that can also occur. And then in some cases, medication. So Alphagan is a medication that is used for glaucoma. It's an eye drop, and it can cause this allergic reaction. There are other types of eye drops that can cause it, but Alphagan is one of the more common causes. I'm going to skip over viral conjunctivitis because we discussed this, but other than to talk about two complications that occur with viral. So in some cases of pink eye, this is a severe, if you get severe pink eye, sometimes you'll get what are called membranes or pseudomembranes. You'll get these, as you can see here, the lower right photo, you'll see that they develop these kind of adherent mucus film that sticks to the inner layer of the eyelids and the eyeball. And we have to kind of strip those in the office because it can become very uncomfortable. In other cases, as the photo on the upper right, if it's severe, sometimes patients will notice that it's changing their vision, and that's because it's causing this small amounts of inflammation or keratitis. So kera refers to the cornea, itis is inflammation. So keratitis, it can cause this corneal inflammation, which causes these small white spots, which can obstruct the vision. This can generally be treated with steroid eye drops and with good resolution, but sometimes they can be chronic or they can recur. Again, this is, if you have any of these things, it's typically highly contagious, more so than the regular viral conjunctivitis, which in and of itself is very contagious. And I'm going to skip these specifically here and move on to follicular. So these are other causes for follicular conjunctivitis. There's a mnemonic that we typically use, adeno, which is the adenovirus that commonly causes this. We say adeno hardly happens to careful nuns. So adenovirus is one, herpes simplex virus, HSV is another. There's hemorrhagic conjunctivitis, which occurs typically due to certain types of bacteria. Chlamydia can cause it. So chlamydia, again, another one that we typically think of as a sexually transmitted disease, but chlamydia can occur due to transmission just from towels and things like that, and it can cause a conjunctivitis in adults. There's something called Newcastle's disease, which is caused by a virus that's a cousin of herpes simplex virus, and sometimes you'll get toxic causes, things like certain kinds of eye drops or contact lens solutions that might cause this. If the patient has chronic follicular conjunctivitis, then we typically want to look for other causes. And these are issues where your doctor may want to take a culture. They may even want to take a biopsy to look to see what else is going on. Oftentimes, the doctor will initially sort of empirically treat for chlamydia. And the reason for that is because chlamydia is a bacteria that can be hard to grow. It grows inside cells. And so it's more difficult for us just to take a swab and culture it in the lab. So because we can't be sure that we're getting an accurate reading from the lab, we oftentimes will just give the patient the treatment, which is antibiotics. That's usually like a single dose of azithromycin or a couple of week course of doxycycline, and then treat also with antibiotic drops there. Molluscum, as I had mentioned, is typically caused by a virus called papovavirus, and this can cause these lesions that are typically very specific. You'll see these bumps that are around the eye. And then what happens is that because it's a virus, the virus sheds, and that sheds into the eye, and that causes the red eye. So bacterial conjunctivitis, again, most of the time, bacterial conjunctivitis will get better by itself, even after a week or two. It's not to say that you shouldn't, consult your primary care doctor and see what it is, but oftentimes we try to move away from treating everybody with antibiotics because we don't want to breed resistance, and we know that the this is a self-limited condition and it will get better by itself. But in some cases, if there's a lot of discharge, if it's very severe, we definitely would like to treat with antibiotics. And there are certain types of bacteria that are more dangerous than others. Gonococcus is one of them. So you think of gonorrhea, that typically can cause this very bad milky discharge. You'll get lymphadenopathy, that's LAD there. That's usually you'll get these swollen lymph nodes, typically in front of your ears here, sometimes below your chin. And for those patients, we have to give them systemic antibiotics and antibiotics on the eye. We want to definitely irrigate until all the discharge goes away because gonococcus can actually kind of really destroy some of the tissues on the surface of the eye. Allergic conjunctivitis, it's again very common. Sometimes, as you can see here on the upper photo, on the left upper eyelid, there's some swelling there, and that can cause some droopiness. So patients typically will have redness, they'll have itching, scratching. Sometimes it's seasonal. People notice that it occurs, every spring or every fall, depending on what they're allergic to. Patients may have other allergies. They may have rhinitis, so runny nose. They may have a scratchy throat. One of the interesting things is that although we have drops for this that can work quite well, for patients that have rhinitis, that have this inflammation in their nose, and that get things like Flonase or steroid sprays, the steroid spray in the nose actually will help with the eyes as well. So oftentimes they don't need the drops in addition to that. So if you're someone that thinks they might have allergic conjunctivitis and you also have problems in your nose, using the spray may be helpful there to treat both things. As an over-the-counter remedy, if you do have allergies and you say, oh, well, this is typical and I'm just getting, my eyes are getting itchy and it's my normal allergic conjunctivitis, there was previously a prescription-only medication called Pataday or Patanol, and that is now available without a prescription. It's called olopatadine, or I think they still use Patanol, but it's available over the counter at any of the pharmacies, and that's typically once or twice a day. It works quite well. It reaches peak effectiveness after about 2 weeks, but typically can start to help right away. So this is what I was describing before, subconjunctival hemorrhage. Here you see one in a small child, but you have one here in an adult on the upper photo. Typically, it gets better after a week or two. It's like a bruise. It's going to change colors, get yellow before it gets better. We don't need any treatment, but we do want to make sure that we've investigated for other causes. Make sure that, I like to tell my patients, this isn't your body trying to tell us that something else is wrong. So things like high blood pressure, or if you have a bleeding disorder, sometimes patients that are on certain medications to prevent blood clots will develop these more easily. Another time that this occurs is patients that are taking steroids, either by mouth or eye drops, can sometimes weaken the small blood vessels or increase the likelihood of developing bleeding. So you'll get more easy bruising on your skin, but you may also get similarly more easy subconjunctival hemorrhage on your eye. If it's recurrent, it's always coming, we can't really find a source for it, then we sometimes want to look to make sure that the patient doesn't have something wrong in their blood that's causing this recurrent bleeding. But generally, I would say for 90% of the patients, it's not anything to be concerned about. So this is the pterygium I described earlier. This is kind of that wing-shaped or triangle-shaped with the apex towards the pupil and the cornea. And it will grow oftentimes with more exposure to ultraviolet light or wind. If it starts approaching the center of the eye or that pupil, we probably want to surgically remove it. There aren't any eye drops to make it get better because we don't want it to cause vision changes or vision loss. In some cases, if the redness persists and patients are unhappy with the appearance or they have constant irritation, we'll take it off for those reasons too. A cousin to that pterygium is something called a pinguecula, which some of you, if you look very carefully in the mirror, you might notice as a yellow or white bump on the white part of your eye, typically close to the nose, but sometimes on the other side here, as well. And that is like a small island on the surface of your eye, and it can become more dry, just like an island. The top of the island is dry, and the sides, the beach part of the island is wet. The tip of that pinguecula is like a bump, and that can typically become dry, which can then irritate the eye and cause some inflammation. If it gets inflamed, usually just artificial tears that are iced or cold will help to reduce the redness. You can also use redness relieving eye drops. There is a drop called Lumify, which is bromonidine, it's available over the counter, and it works very well for red eye. It doesn't tend to be I don't want to say addictive, but your eye won't get addicted to it the same way it would to Visine. So if you find that you can use it more frequently if you need to, but that does a very nice job of causing the redness to go away, and that may be enough. But if it's not getting better, then sometimes we'll treat with steroid eye drops, something anti-inflammatory. With the small bumps, the pinguecula, I'm generally reluctant to take them off because they have a high rate of coming back, and they come back worse. So I try to leave them alone as much as we can. Keratitis or corneal ulcer, there's infections. What you can see here, if you look in the mirror and you typically see a white spot on your cornea in front of the colored part of your eye, and the eye is red, you should go see your doctor. That could be, especially if it's painful, because that's typically a corneal ulcer. In the photo here on the right, you see that what's called a dendritic keratitis. So this is dendrite, comes from dendritiform, which typically means tree-like or branch-like. So you can see it looks kind of like tree branches there. That's caused by the herpes simplex virus. Most often patients have red eyes and they have irritation, not so much pain, but they can have pain. And both of these require treatment from a doctor with prescription medication. If you have something like this, if you get a red eye and you've had contact lens wear, especially if you've been sleeping in your contacts, or if you've gone swimming with your contacts or wearing them in the shower, you got water in the eye while you're wearing contacts, all of those are risk factors for infections, and we want to make sure that we take that into consideration, we culture and treat that appropriately. And I'm going to take a pause here because we're getting close to 8. I want to continue, but Dana, do I have a time frame here on the talk?
Dr. Kedhar, I would suggest that if you would like to take a few questions, people tend to stick around if they're interested, and if they need to leave, they will. But I think your information is worth having.
Okay, so why don't we do that? Why don't we take some questions here, or let's see where the chat is. Are you able to bring up, or can you bring up the questions for me?
You know what? I don't know if they're messaging you directly. We have one in the chat, and that question is, are there any secondary effects while using Lumify?
Okay, so I think that probably the biggest, okay, I see some here now. I think I'm okay. I would say the biggest concern with Lumify chronically is just irritation from the eye drop. Sometimes preservatives that are in the eye drop can cause further dry eye, and so are we okay?
I think somebody took themselves off mute.
Okay. Yeah, so I think that if Lumify should be fine. It's something that if you find, if you find that you're using Lumify every day for weeks and weeks on end, you probably should see the doctor to see what's causing redness. But if it's just a week or so, it's probably fine. So chronically, yes, Lumify could cause problems if used for a very long time, but in the short term, for a couple of weeks, I don't think it's going to cause any problems. All right, let's go back here. So the first question was, what are your best tips for keeping warm compresses warm? So I think that using the towel approach, where you soak it and then put it back on the eye, it's not great because it loses its heat after 30 seconds to a minute, but it is the cheapest option. Another option is there's a lot of commercially available masks that have kind of a little bit of moist, they're moist and they have something that retains the heat. You put them in the microwave, put them on your eyes, and those last for longer. Those are more sustained, consistent heat for 5 minutes. And so I would say that I would probably try to use one of the commercially available masks. There's a number of them. You can go on Amazon. They're usually pretty cheap. You don't need to spend a lot of money on them. And those can be helpful there. There's a direct message here. I'll answer that at the end. It's the question that was asked, Miss Kelly. I think it may be a little bit difficult for me to answer that without other additional information or question or a full exam. So I may not be able to answer that appropriately. Susan C asked, what do you think of blink eye drops? I think blink eye drops are great. Preservative free, you'll find that a lot of doctors recommend preservative free. There is a little bit of a contention there, and some people feel that there is not strong evidence to show that preservatives necessarily cause problems. There is a preservative called benzalkonium chloride, or BAK, which is in a lot of the generic artificial tears. And I do think that that causes some problems. And so I think it's better to use preservative free in those cases. I think Blink and Refresh use different preservatives. I think Refresh uses something called Purite, which doesn't seem to have as many issues. I think if you're using the drops more than 4 times a day, probably preservative free is better. But if you're using it 4 times a day or less, then I think that's okay. Another question came about Systane eye drops. Systane eye drops are great. With regards to different types or brands of artificial tears, they're a little bit like brands of shoes. Some people like one, some people prefer another, and I think you have to try them to see which one makes you feel better. In addition, even within brands, there are different sort of levels of eye drops, and some of them are thicker and some of them are thinner. So the thicker eye drops might make your eyes feel better. The thinner eye drops may not make your eyes feel as good, but your vision will be clearer. In other words, the thicker eye drops might blur your vision for more. So sometimes people advocate using the thinner eye drops during the day when you have to do your reading and things like that, and then the thicker eye drops at night before you go to sleep, just so that you can kind of coat the eyes. But again, brand wise, I don't really necessarily recommend one brand over another. I will address one thing that may come up. In the news several months ago, they had talked about the people getting severe infections and some life-threatening infections from eye drops. Those were caused by very specific generic eye drops that were produced by a factory in India, if I recall. Many of the eye drops are fine, and I don't want to cast any aspersion on generics because many of them are the facilities are investigated or monitored by the same people that monitor the facilities here in the United States. But it was very specific. We haven't really had those issues with the brand name eye drops in the U.S., things like Systane or Refresh or Blink. And so I think that those probably are fine. And I think those would be my first choice over, say, a CVS brand or a generic in those cases. Let's see. Yes.
May I? Hello, Dr. and Ms. Kelly. May I offer some feedback? I don't know what the problem is. I'm a patient at Gavin Herbert. I see Dr. Riazi every 4 months for my eyes. And being a patient, I'm on the list, and I've registered for them. But tonight, when I tried to get in through Zoom and even Google Meet, I'm an IT person. I'm pretty skilled at this. I was only able to come in as audio. I cannot see the presentations of the slides. I can hear you, but I don't know what the problem is, but Zoom kept over and over again asking me to register. And when I'd say save, nothing happened.
All right, so can we just so what we'll do, Will Alvarez, can you would you mind?
Can I jump in here?
Yeah.
We're recording, sir. I'm so sorry you've had this problem, and we'll look into it to make sure we try to avoid that in the future. But we are recording this lecture, and it will be sent to everybody who's registered for this meeting. So you'll get a copy of it in the next week or two once it's been edited and available. So thank you for hanging in there. Sorry about the technical difficulties.
Yeah, and I'm not sure if
Is there someone I can contact? about, you know, maybe there's something wrong in the database in my account that
No, it's
causes me
not.
to.
We've encountered that problem before. We'll have to look into getting that sorted.
Okay, thank you.
Yeah,
You're
I'm
Ms.
sorry.
Lee?
That's
Okay.
Dana Collinson.
Dana Collins. Okay, thank
Yeah.
you.
Yeah, you're welcome. And I apologize. I'm sorry that you're having some technical difficulties there.
Yeah, it took me till 7:35. I almost missed most of the presentation.
Well,
Well,
we'll make sure that you get a copy. Please let us know if you don't. So
Okay, thank
we can
you.
get you the information. So another question is, how do you evaluate if it's allergy? So usually we'll talk about symptoms and we'll ask if there are particular factors that may aggravate or alleviate that. When patients describe seasonal changes, and typically if there's itching and burning associated with it, and it's seasonal, it's more likely allergy. If they have a history of allergies, we might also indicate that. We can also look, as I said before, if you look at in the doctor's office, we can actually look at the undersurface of the eyelid. We can kind of flip it. It's that thing that we all did as kids to scare our siblings or our parents. But you can look and see if there are bumps. And if there are bumps there that are papillae, then that's more indicative of an allergy. And so if the patient has the other symptoms and has those bumps, then that indicates that probably there's an allergy there. So again, most of the time it's going to be symptoms, but sometimes we'll find these other signs that will confirm that diagnosis for us. Once an eye drop vial has been opened, is it okay to use what's left during that same day? Yeah, I think that in general, for a lot of these preservative free, so what they're describing is a preservative free eye drop that comes in those single tearaway vials that you tear off the top, put the eye drop in. And there's oftentimes more than one eye drop in there. And so you say, well, gosh, I'm wasting all of this, right? So preservative free means you shouldn't be using it the next day, but probably for that day or at least half the day, it's probably okay. I think what I would suggest is most of them have a cap that you can put back on. I'd put the cap back on. You want to make sure it's not, continually exposed. And I'd probably put it back in a fridge or something refrigerated. Should keep it going a little bit more, and you should be able to get a few more drops out of it. You do have to be careful. I think that in the most conservative sense, using a single eye drop is the safest thing. But I have many of my patients that use these preservative-free eye drops for, again, not for several days in a row, not even for the next day, but for that day over the course of the day, from like 8 to 4 or 8 to 5 kind of thing, and that's probably fine. Questions about a massager device with heat for dry eyes. Yeah, there are different things that people can use, and there are a lot of different ones that are available over the counter. Again, I can't really recommend or suggest one over another, but it's like the brand of eye drops, right? It's unlikely any of them are going to hurt you. So I think if you try one that you feel is going to work for you and seems to be working, that's fine. If one's not working and you want to try something that's a little bit different, I think that's okay too. All right, so another question about the use of a specific type of steroid eye drop that was used, and when it was switched to the generic version, the patient noticed. So this is I'll broaden this to something that occurs with a lot of different. A lot of patients will say this. They're using the brand name of one and they switch to the generic and they feel like it doesn't work as well, or it's a little bit different. These things, generics are not always exactly equal to the brand name. They can have other ingredients that are in them, the way they're prepared, maybe the pH is a little bit different. So all of those things can contribute to not feeling as good. It's not common that the generic is not as effective as the brand name, although that does occur. So I think if you're not feeling good with the generic and the brand name felt better, then getting back to the brand name would be more appropriate. Sometimes that's not possible because once the generic occurs, they just stop making the brand name. But if it's feasible and the brand name works better for you, going back to the brand name is fine. And Sorry, and Alex Wang, sorry, we got interrupted when I was about to read your question, so I appreciate you bringing that back to the chat. You heard me mention that eyes get addicted to eye drops. I think that was I probably misspoke a little bit. So let me rephrase that to say that there is something called tachyphylaxis, and so what happens is that all of these. Let's take Visine for instance. Visine is a drop, and what it does is it acts on receptors in the blood vessels that cause the muscles in the walls of the blood vessels to contract. So it shrinks the blood vessels. That's why your eyes become less red. But if you keep giving it that drop and the receptors keep, receiving that medication, your body will try to counteract that and it'll produce more receptors, or the receptors themselves will become less responsive to the drop. And then what happens is you have, the blood vessels are dilated, your eyes are red, you put a drop in, and yeah, it doesn't work as well as it did before. Or maybe it lasts, but it doesn't last for the 6 hours it lasts for 30 minutes. Now you need to use more. So it's a similar way to, we think about that in terms of addiction, right? People that use a lot of a particular drug, they use a little bit, and then they find that, okay, well, now I'm using this amount and I need to use more to get that same effect. So that's kind of what I was attributing that to. You don't really have that with artificial tears. And I think that's the end of the chat questions. So Dana, we're at 10 after 8. Should we continue here?
I would say if you have more information to share, please do. And if people can stay, that's great. And if they need to leave, we understand.
Yeah, we'll do it. All right. So let's move on to iritis. So iritis is a form of uveitis. So uveitis is inflammation on the inside of the eye. And iritis is inflammation in the front part of the eye. So if you recall what we were talking about with the anterior chamber, so that's the space between the cornea and the iris, the colored part of your eye, there's fluid there, and sometimes we'll see these white blood cells. And sometimes those white blood cells will accumulate on the back of the cornea. So you can see that in the middle photo here, those white spots. Those are actually like nests of white blood cells from your bloodstream that have accumulated on the inside of the eye. And that's called iritis. Typically, patients will complain about photophobia, which is light sensitivity, or remember our slide from the beginning, RSVP, right? Redness, sensitivity to light, vision changes, or pain. So sensitivity to light, this may also cause pain as well. And the reason this is important is because you really need steroid eye drops to treat this. It's not going to typically get better by itself. And in about 50% of patients that have this, it's associated with something going on elsewhere in their body. So that may be arthritis. It may be other types of inflammation. Sometimes it can be infections like syphilis. It can be infections like tuberculosis. And so when patients have this, and we see them, and these are the patients that come in to see me for consultation or are referred to me, we usually have to take a full history. We want to see what's going on. I typically will, examine other parts of the patient's body. We'll look at their skin, try to figure out if there's other things that may be connected to it. We'll do some blood work, chest X-ray, and then we'll treat the patient. And typically we'll give patients steroids and a drop to dilate the pupil, because we worry sometimes with constant inflammation that they'll get scarring between the lens, that's the part of the eye that becomes a cataract, it's behind your pupil, and the iris, which is the colored part of your eye. So as you can see in the lower photo here, the pupil is not round. It looks irregular, and that's because there's various points along that the contact between the iris and the lens that are causing scarring. So the pupil's not dilating in a round shape the way it normally would. There's scarring. So again, if you have light sensitivity and redness, especially if the redness is perilimbal, the limbus is the outer edge of the colored part of your eye. And if you have redness and kind of more densely in a circle around that spot, that may be more a sign of this iritis. And there we go. Okay, and then I also wanted to discuss angle closure glaucoma. So in some cases, if you have a red eye, if the eye is painful, and typically you see halos around lights, oftentimes it occurs in the evening because that's when the pupil dilates, or movie theater, things like that. And it's fairly painful during that time, so it's not something that's subtle that you're not going to notice. But it typically causes pain. And the reason for that is if you look at the photo at the top in a healthy eye, what happens is there's a space there. Let me see if I can annotate this. Usually the eye produces fluid here, and the fluid flows with these arrows through into the front of the eye and out another drainage canal, which is pretty close by here. So it has to go through the pupil and around the iris to get to the drainage canal. But in some patients with closed angle or angle closure glaucoma, what happens is that the iris here, as you can see, kind of gets pushed against the drainage canal of the eye. So the fluid builds up behind the iris. And that makes things worse. It actually pushes the iris closer to the drainage canal, further closing that off. Then the fluid that's building in the eye has nowhere to go. It keeps building and building and building. So it's like blowing up a balloon. You blow up a balloon, keep blowing it up. Pressure gets very hard. And again, we were talking about before, when the pressure gets very high, that causes nerve damage, and nerve damage takes away your vision. So we want to make sure if that happens, that's something like you don't even want to wait overnight, right? If you have a painful eye like that, if it's very painful, you have a headache, if the pupil is kind of mid dilated or dilated, not small, but wide, then you want to get to your doctor, get to the urgent care, get to the emergency room so someone can take a look at you. And I think one of the last things I'm going to talk about here is something called episcleritis versus scleritis. So one of the more common reasons for red eye is something called episcleritis. And usually people will say, oh, I woke up and it's red, but it's only red in a sector. It's like one area of the eye. It's not the whole eye is not red like you typically have in a conjunctivitis. It's like, oh gosh, I look over here, my eye's white, it's all fine, but it's just this one area that's red. And that's usually due to some sort of external inflammation or external, irritation. So it can be due to allergy, dry eye. I commonly see it in patients who they haven't slept, they didn't get a good night's sleep, or they were on a trip and they were, up for hours and hours on a flight, and they got home and they noticed, and the redness, it stays, it doesn't get better, over a couple of days. Typically, it's not painful and it's superficial. And if you touch it, if you kind of close your eyes and press in that area, it doesn't hurt. And that's usually a benign kind of inflammation. Usually it gets better on its own. You can use the aforementioned cold artificial tears can help. Lumify or Visine can sometimes constrict the blood vessel and help until it gets better. But if it's not getting better after a few days, or if it's painful, definitely come in so we can take a look, and we can sometimes give you medicated drops like steroids that will reduce the inflammation, get that to go away. I will say for patients, the one time I get more concerned about sort of a systemic disease is if it's really recurrent, if it keeps coming back. I will sometimes, the same way I do that for the uveitis patients, I'll look, do a full exam, we'll take a history, we might do some blood work. But also in patients that have inflammatory bowel disease, so these are diseases like Crohn's disease or ulcerative colitis, sometimes they'll develop this episcleritis, and that can be actually a sign that the disease is not well controlled, even if they feel okay otherwise. And so in those patients, sometimes I'm more careful to send them back to their gastroenterologist so that they can, monitor and make sure that the disease is not kind of on the rise or getting worse. In the photo on the right, you'll see that it's much more red. So this is something called scleritis. So sclera is the white part of the eye. It's underneath the conjunctiva. When the sclera gets inflamed, that actually can be a warning sign of something more serious in the body. Again, just like uveitis, almost half of these patients will have some sort of systemic disease, and some of those diseases can be life-threatening. So these are cases where we always want to make sure that when the patient has something like this, we're getting some blood work, we're investigating, we're looking to make sure that we're not, the body is not trying to tell us through the eyes that there's something more seriously wrong. Generally, these are painful. Patients describe a deep, boring pain, like a drill going through the eye. It may be worse in the morning or at night when people are trying to go to sleep. And usually it looks not just red, but sometimes almost purple. And if you touch it, it's pretty painful. So again, if you have any of those symptoms, get yourself to your eye doctor right away. Kind of talked about that. And so, I'll end there, and just to say thank you very much for joining us. Truly, this is one of the things that we really value as physicians and as professors here is our ability to talk to patients. We try to do as much education as we can when patients come to see us in the office, but we don't have an indefinite amount of time, and so being able to spend more time with you and explain things like this to a broader audience is really rewarding for us, and I really appreciate you all taking the time out to listen. So with that, I will end here. There are, I think, a few, let's make sure there aren't any other questions here that need to be asked. I think those were addressed. Very good. I think those were all the questions. So I'll leave it at that. Dana, are we good? Do we need to?
We're all set. Dr. Kedhar, thank you so much.
Okay.
And I know everybody appreciates your expertise and the fact that you were taking excellent care of a patient, and that's why you were a few minutes late. So I put a message in the chat, everybody. There's more lectures coming up in the rest of 2024 and recordings of our previous ones on our website, ophthalmology.uci.edu. And you can expect to receive a copy of this lecture in the coming weeks once it's been edited and posted on our website.
Yeah, please do join us. My colleagues are great. They're excellent. So
thank you very much.
Okay. Take care. Good night, everyone.
Good night.